COVID-19 articles are open access. So if you need a COVID-19 article from the CJA, you can get it online. He's also the professor in the Department of Anesthesia, Perioperative and Pain Medicine at the University of Manitoba. Next up, I'd like to introduce Randy Wax, who's an associate professor in the Department of Critical Care Medicine and regional director of clinical care in Durham region at Queen's University. He's published an excellent review article, which we will reference during this presentation, and I strongly encourage you all to read that. Next up, we have Laura Duggan, who is an associate professor in the Department of Anesthesia and Pain Medicine at the University of Ottawa, and she has been instrumental in getting the Canadian Airway Focus Group involved in dealing with this issue. And finally, Shannon Lockhart, who is in Vancouver, BC Women's in St. Paul's, and she has been actively involved in coming up with guidelines for the BC Women's, St. Paul's, and actually BC response to COVID-19. So I'd like to welcome all of you. So again, as I said, this is an evolving issue. Absence of evidence doesn't mean evidence of absence. And I think what we're going to try and focus on today is that as healthcare workers, we need to stay safe while we're dealing with patients. And what we're trying to come from is from a place recommendations of safety. I should introduce myself. I'm Dan Bainbridge, and I'm the president of the CAS, and I'll be moderating this. And just briefly, this is Randy Wax's intensive care paper review article on management, both anesthesia and intensive care of COVID-19 patients. So I thought we'd start with a case, and this is just a COVID-19 patient on nasal prongs who requires IV medication. And I'm gonna ask Dr. Duggan if she would just take us through what are the issues involved in a COVID-19 patient where you're asked to start an IV.
Thanks, Dan, for the introduction, and it's such an honor to be here. We are now full. There is 999 people online, and I think we're all worried, and I think we all need a common approach to this. I just want to go quickly through what the issue is in terms of a COVID-19 patient. It is confusing about aerosolization versus airborne versus droplet precautions. And I never really thought that my jet ventilation research or my aerosolization for Ventolin in kids research in the 1990s would come in so handy here. And so I'm just going to ask for this first slide of the video of somebody sneezing, because I think a video is worth 1,000 pictures. So next slide, I do believe. Sorry, the one after that has the video of the person sneezing. And I'm just gonna let everybody know that this is going to be somewhat rough in places because we just did put this together a couple of days ago. So thank you for your patience. Can you play that for me? So this is a person sneezing, and this is actually understanding fluid dynamics and disease transmission out of MIT. And as somebody sneezes, you can see droplets start to fall on the ground and around their contact area, usually dropping within 1 meter. Droplets are defined as greater than 5 microns. They tend to be the heavier pieces. And you can see the airborne stuff, the stuff that's further away from the patient, parallel to the patient's mouth, is starting to go up in the air, generally less than 5 microns. It's confusing because you hear airborne, droplet, and then now aerosolized. And the aerosolized component is the thing that we are most worried about in terms of invasive procedures such as airway management. And there's the aerosolization that is a combination of both droplets and airborne. It's just a grab bag of different microns, and it just simply goes everywhere. So can I get the next slide, please? There, great. So just as a review, and these slides will be available to you, airborne is one thing, and we've been really looking into airborne and whether that's a way that this is infectious. And thankfully, unlike tuberculosis, for example, we don't think airborne is actually where the money is, where you get infected. Droplets become contact when they land on the ground. So contact and droplet precautions for sure, hence the 2 meter distance between people as a buffer zone. But aerosolized is where it's at. It's thought to be the highest concentration of contamination because of its combination of several different types of microns and just its huge number just coming out of the patient's mouth. Thanks, Dan.
Okay, thank you. So let's go back up and discuss the patient then.
So,
and maybe.
Sorry, Dan, can I just mention one other thing? Aerosolized precautions occur during airway management procedures. So aerosolized stuff that comes out of the patient's mouth isn't necessarily when a patient is asymptomatic and COVID positive. It's when we actually do intubations and bronchoscopies and other invasive things. Sorry.
That's fine. So, Dr. Lockhart, do you want to discuss what sort of precautions you would put on for this patient then?
Absolutely. So as Laura's just demonstrated, the primary mechanism of distribution when someone's sneezing and coughing is droplet and contact. And so if they're not having an aerosol generating medical procedure performed, which this patient is not, starting an IV is not an aerosol generating medical procedure, we will go through the list of AGMPs, as we call them, on a further slide. But I think we can all agree that an IV is not an AGMP, an aerosol generating medical procedure. So this particular patient would require routine droplet and contact precautions. And so what that consists of is a reusable yellow gown, nitrile gloves with maximum cuff coverage over the gown and the glove, as well as a surgical mask and some type of eye protection. At some sites that will be goggles, at some sites that will be a surgical mask with visor. So this COVID-19 suspected or diagnosed patient does not require airborne precautions. So respiratory and droplet precautions if you're going in to do a non-aerosol generating medical procedure.
Okay, can you also comment, the patient should have a mask on, should they not? This is an isolation line or nasal office, but this should be walking into.
Correct. The patient should have a mask on. Thank you.
Okay, it's Randy. Just to clarify, yeah, the mask over the nasal prongs, right?
Correct. Right. So the nasal prongs is underneath the mask. They have a mask on the outside.
Exactly. Perfect.
Okay, so I think the next slide should be the intubation slide.
Okay. Are we going to talk about aerosol generating medical procedures then, since we decided that IV start was not?
Yeah. Okay, so the difficulty, as Dr. Duggan alluded to, is differentiating between droplet and contact precautions, which are required for non-aerosol generating medical procedures, and airborne precautions, which are required for procedures that generate aerosols. And the difficulty is that, unfortunately, in the literature, and even through the SARS time, there's been lack of precision in the definition of what are aerosol generating medical procedures. So now we're faced with making this crucial decision about what precautions to adopt when the definition of what are actually procedures that generate aerosols is quite controversial. So what I've done is I've pulled this quote from the World Health Organization guidelines defining what aerosols are. And then from the literature, what has definitely been defined as aerosol generating medical procedures, you can see on the left. So intubation is the highest risk based on odds ratios. And I think Dr. Duggan will go through that literature. Tracheotomy is also defined as high risk, non-invasive ventilation, as well as manual ventilation. What's controversial is, and I know it says non-invasive ventilation definitely, however, there's various forms. So CPAP, BiPAP versus OptiFlow. So OptiFlow is very controversial. High flow dry gas, so that's nasal cannula and simple masks. CPR, endotracheal aspiration, open airway suction, nebulizers, bronchoscopy, NG insertion, sputum collection. And now the testing for COVID itself has brought up, well, are nasopharyngeal swabs aerosol generating? And so this has caused a lot of controversy. So the overarching theme is that if you are performing an aerosol generating medical procedure, you should have airborne precautions. However, you likely will have to work with your site to determine what your site is defining as aerosol generating medical procedures. Because in a resource limited setting, as we're in now with PPE, if we were to say that everyone doing any of these procedures is to don an N95 mask, the risk would be that we would run out of N95 masks. And so what's happened at our site is that experts have gone through the literature and made a list here of what is reasonable for us to define as aerosol generating medical procedures. What we've also done is defined intubation as the highest risk. And so this will require a level of precautions that we are defining as intubating precautions, which offer neck protection, and so a little bit of extra protection from the other aerosol generating medical procedures. So just to summarize, there's respiratory and droplet and contact precautions which are required for the IV patient or any procedure that doesn't generate aerosols. The other procedures that you see in this table require airborne precautions. If you're performing intubation, which is the highest risk for generating aerosols, there is a question of whether you might want to have some form of neck protection added to your airborne precautions. So potentially an enhanced airborne precautions category.
Could you comment on extubation? Where would that lie?
Yeah, so unfortunately, there's no literature on extubation. And so at our site, we've put extubation with intubation because, as we know, it's a high risk time for coughing, open airway suctioning, disconnecting of the circuit. But again, this is a working progress, and by no means have we finalized that. But at this current time, as we see these patients and make decisions, we are defining intubation and extubation as higher risk aerosol generating medical procedures.
Okay, thank you.
Mm-hmm.
So I'm just going to move to this one. And Dr. Duggan, do you want to go through what the AGMP risk is?
Well, I'm just going to follow up on what Dr. Lockhart just said, which is it appears to be, and this actually, I would suggest to everybody online that they look up this journal article because it really is on point for the questions that you have for your own risk. In terms of aerosolized generating medical procedures, an odds ratio is the ratio of you getting the disease compared to general healthcare professionals. And so active positive pressure ventilation through a mask, such as seen on the left side, has an odds ratio of 3, which is why we aren't recommending bagging a patient post-paralysis during airway management. Intubation, which can be seen in the central panel, has an odds ratio of 6. This is the highest odds ratio for any invasive procedure for a patient who has active viral COVID infection. And finally, even though cricothyrotomy is not known what its odds ratio is, I'm going to assume that it's a similar odd to tracheostomy, which we do know has an odds ratio of 4. So all the things that we do as active airway management, as active airway management managers in acute care, carry odds ratios that are much greater than even other aerosol generating procedures, yet alone bedside care. We really are in the front lines of the chance of getting this virus as a result.
Okay. So while we're on this, I'm just going to put you on the spot a bit. And what's come up a few times is ECT. And that would then probably depend on whether you bag mask the patient or whether you may have to bag mask the patient in terms of the risk that you're going to put yourself at during an ECT treatment. Would that be accurate?
It's interesting. It's I guess because it's such a generalizable procedure, we've had a lot of questions about this, and I think first of all, we need to, as Dr. Lockhart just said, figure out if a patient actually is at risk or not. Again, we don't want to be using up all our PPE equipment for people that actually are a low risk or have been COVID negative. So we need to sort that. And I think, having droplet precautions for any patient is actually an extremely safe thing to do. I think asking the patient to hyperventilate so we don't have to positive pressure ventilate them afterwards to induce a seizure is very reasonable. And in terms of ECT, there may be some benefit. Early days, we'll probably have more information by even next week. Things are so rapidly changing, but it wouldn't be unreasonable if you cannot get a seal as the patient is emerging that an LMA be placed. So again, this is an evolving area. Obviously, people that need ECT, this is not an entirely elective procedure, and I think we need to continue to work on the evidence. So I can't really give a clear message right now, but I think there's ways that we can avoid positive pressure ventilation between induction to ECT.
Okay, thank you. Does anybody else on the panel want to address that issue?
I can speak to this. We do have a protocol set up at our hospital. Can you hear me?
Yeah, go ahead.
Yeah, okay. Okay, so what we've done is liaise with our psychiatry colleagues and ask that all non-emergent ECTs be reevaluated. We've really emphasized the significance of performing ECT during this time, and so only inpatient and essentially emergent cases are done. And so what we've said is that anyone who has tested positive will not be done for ECTs until the patient is asymptomatic and has tested negative. For airway management, given that bag mask ventilation is an aerosol generating medical procedure, we've advised this be avoided if possible. What we've done is used a modified technique. We use a 2-hand seal by the anesthesiologist, and the AA or RN will perform low volume bag mask ventilation with an oropharyngeal airway to minimize the leak. In our opinion, performing the task of endotracheal intubation puts us at higher risk than this, as you've seen from the odds ratios that Dr. Duggan presented. And then other options, we're still discussing elective LMA or elective intubation for these patients. But at this point, we've settled on good bag mask ventilation with a 2-person technique with an oral airway. Again, obviously, if the patient has a beard or anything making bag mask ventilation difficult, this would need to be reevaluated, and possibly a supraglottic device would be a better solution in these patients. We feel like the potential for coughing on extubation for this short procedure is likely to increase risk of exposure of aerosolized particles. And so if necessary, techniques to minimize coughing should be considered, including remifentanil and deep extubation. For post-procedure care, we're using nasal prongs and face mask at a high flow, we're saying that high flows of nasal prongs and a simple face mask could cause aerosolization. And so we're opting for low volume two-handed technique with the AmbuBag post procedure.
And what PPEs are you wearing if they're low risk or high risk or / positive for COVID?
We're currently wearing routine droplet precautions for all ECTs, and we're not doing COVID positive patients. If they're suspected or positive, we're not doing ECTs. We just don't, unfortunately, at our site have an N95 supply that can support that procedure.
Okay, so you're doing ECTs in low risk COVID patients, and you're just using droplet precaution.
Yeah, routine droplet and contact precautions.
And contact, yeah. Okay.
Sorry, it's Randy. Probably just to clarify. So when you say low risk COVID, what you're saying is that they either have no symptoms and or that they've actually had a swab and are negative, correct?
Correct, and that will be evolving as community transmission increases. Pretty much every patient coming in will start to be considered high risk. However, even if they're asymptomatic. However, at this time in our community, we're almost at the place to transition to that, but we're not there yet. So it would be something that you would need to evaluate for your particular community, the risk of community transmission.
So Dr. Wax, do you want to comment on that in terms of risks? And in terms of, are we at a unified risk across the country, or is this a local, regional risk?
I mean, I don't think there's any doubt that there's community spread of COVID, and every jurisdiction's slightly different. But what I can tell you, certainly, what we learned from SARS, it's actually not the patients that you suspect have COVID that are going to get you. It's the ones that sneak in that are completely unexpected. So I think, if you have things that are potentially elective or can wait, if there's any doubt, being able to clear them with swabs that feel comfortable that they're truly COVID negative is a smart idea. Our definition of what's elective and urgent and emergent, I think shifting based on, turnaround time for testing and risk and balancing all of these things. So it's definitely an evolution, but I think a little bit of paranoia is not a bad thing. I think if you, certainly travel history is, I think, completely useless at this point for deciding whether somebody's high risk or low risk. So it's in evolution, but anybody coming in with febrile respiratory illness for sure, I mean, you got to suspect that they're COVID until proven otherwise.
So does that mean everybody in the hospital should be wearing masks if they're a patient?
Again, if we had an unlimited supply of PPE, that would be something that people would be thinking about. One of the interesting shifts that's happening, though, is initially there was a real push in terms of PPE conservation to tell people, not to wear masks, either surgical or N95, on the clinical units when you're not doing procedures. And I think what we're finding as a strategy for PPE conservation is, in fact, as long as your mask, you're not playing with your mask, and as long as it's not contaminated, a lot of hospitals are now shifting towards basically, while you're on a clinical unit with patients with COVID and you're going in and out and seeing patients, you're going to be wearing typically droplet masks all the time. And so I think you're going to be finding more and more hospitals are going to, in order to conserve the use, people, when they start their shift and they're going on a unit, will be wearing a mask. So it kind of takes us back to, again, what happened during SARS is anybody in a clinical area was potentially wearing a mask. So you got to be in touch with your hospital to clarify when they're making that shift. But I think you're going to find that that's going to be an evolution.
Okay, thank you. So I think we want to move on and talk about the meat of this, which is the PPE for any procedures that cause airway spread. So I was wondering if we could maybe discuss a case, and maybe I'll get some feedback from the members of the panel. But I thought we'd start with just the simple case of a 49-year-old who is COVID positive, and they're calling you to intubate the patient because they're in respiratory distress. They're on 5 liters nasal prongs, 5 meters mask. And can we just go through that sort of scenario in terms of what everybody is doing in terms of personal protective equipment? And maybe I'll start, Dr. Duggan, I'd start with you first. Do you want to go through what sort of equipment we need to deal with this?
I wonder if we can start with Shannon first, because I think she would like really get our foundation going well.
Dr. Lockhart, do you want to start then?
Sure. Yeah. I have to say, at our site, our personal protective equipment for aerosol generating medical procedures, specifically intubation, which we are classifying as higher risk, has evolved significantly through the use of simulation with glow germ that has demonstrated significant neck contamination. And I'd like to emphasize that this skin contact is not a nidus of not a route of transmission for COVID. However, given the fact that it is so close to the mucous membranes, it's very high risk for self-contamination. And so you touch your neck and then you touch your mucous membranes. And actually, after performing the SIMS, we realized there is significant droplet spread onto the neck region of people intubating, so both the intubator and the assistant. And then we went to the literature and actually found a CMAJ article by author named Zamora to corroborate this. And so based on that, we've evolved our PPE to provide neck protection. I think there's evidence in the literature that during SARS, neck protection was an issue as well. The item in our hospital that's available to provide neck protection is the coverall with a hood. I know this isn't available in every site, and so I don't think it's reasonable to make a prescription that this is what should be used, but I would recommend airborne precautions and that site finds a way to provide neck protection for their practitioner. And then practitioners should consider showering after the procedure with a real emphasis on not touching your mucous membranes until you've fully showered with soap and water.
So I'm going to bring up that slide just so that people see. Sorry, we're passing through different ones, but this is sort of what you're talking about now. Is that correct?
That's correct. So we started off on the left, and through the simulations, we discovered two things. One, that our reusable gowns that were being recommended, unfortunately, have been processed so many times that they no longer have the AAMI permeability level that they originally did when they were purchased. And so they were actually permeable to fluids. And so we then modified to a surgical gown, which has a level 3, AAMI level 3, which is sufficient for moderate to invasive procedures. You'll see on the left, there's no neck protection. So we have, what was available to us at that time was a OR hood with ties that offered some neck protection. And in testing this actually did significantly reduce the amount of neck contamination for the practitioners, but we were still recommending showering. And then what we discovered was available in our hospital through liaising with stores and distribution was these coveralls. And these are actually AAMI level 4. So that's the highest level of permeability protection offered for PPE. And so we've actually moved towards trying to source these coveralls. And this is what we're recommending for intubating and extubating in our hospital.
Okay. Hillary, do you want to just talk about how we put the stuff on and how we take it off?
Sure,
Donning and doffing, I think, are the terms.
Great. Firstly, to Shannon and Laura and Randy and Dan on the line, these are really informative pieces, and I just want to reemphasize again how evolving this is. And I can tell you, in my own institution, the slide on the picture on the left with the surgical gown was with the yellow gown was what was recommended. But I think this is a highly evolving situation, and Shannon, you've really provided some good evidence for why we really need to protect our head and neck, much better. Any way you look at this, though, the high risk which you've identified is the procedure itself, but also the high risk time point is that self-inoculation that can occur during removal and the doffing process itself. And I think this really sort of speaks to the importance of proper training. It's one thing to see a video of this happening, another thing to do it yourself. And I think the doffing procedure is critical here, and the training that needs to be done, I think, can't be overemphasized.
I would
So-
100% agree. Sorry, can I just say one thing? And actually, in training with these coveralls, what we've discovered is while you're, it's not very clear, but there's an adhesive flap that covers the zipper. And so while people are removing this and undoing the zipper, they were contaminating their scrubs. And so what we've done is added a yellow gown beneath this. So even with the coveralls, it's still an evolving process. And I would say that the coveralls are the most difficult to doff. And so if this is something that you're going to use, it definitely requires practice.
It's Randy, just to add a few tips if you're going to go to the coveralls. First thing, like if you're going to wear a gown, actually, my advice would actually be to wear the gown actually over the coveralls rather than under. So the challenge with the coveralls is that opening and unzipping the front and then trying to get out. So what we found a few things. First of all, having what we're calling a safety coach or safety officer helping with the doffing on the way out is really important. And key things related to the coveralls. One is getting that hood off, and the person's got to basically like roll the hood and roll it up sort of as they're helping get it off the back of your head. So typically we've got a safety officer wearing sort of contact droplet precaution, and they will help you get that hood off and keep it from brushing against the back of your neck. And then the second piece on the front, one of the tips that we've used is we actually tie some ribbon, like a long piece of ribbon, to the zipper itself, because where you end up contaminating yourself is in these coveralls, the zipper unfortunately tends to be fairly small. And so as you've got that open area where you're trying to pull the zipper down, you end up brushing against things and potentially contaminating. But if you tie a ribbon to the zipper, then what you can do is actually grab the ribbon below where the zipper is actually opening up. And then you actually can pull down so your hand is never, and your wrist is never close to where all of that is opening up. It works really well. But the last thing I'd say is if you're going to use a gown in addition to all of this, if you wear a gown over top of the coveralls, then what you do is you prevent a lot of contamination in the front part of the coveralls, which is the biggest challenge other than the hood when you're trying to doff that. So I think a lot of hospitals have tried to avoid putting layer upon layer upon layer of PPE because, the more steps that you take, every time you have a step, you have the potential to contaminate yourself. So trying to keep it simpler is better. But if you've been finding that you've been having issues with that, I would actually recommend you wear a gown over top of it. Get rid of the gown. You've gotten rid of 99% of the contamination on the front of your coveralls, and then the doffing is going to be a lot less risky. But you got to balance that with the extra step, and you got to balance that with recognizing if you use the gown on front, you're taking away that gown from other use. So that's just a caveat in that.
Okay, Randy, it's Hillary here. Just let me sort of reiterate that this is an evolving situation, and the availability of these various PPEs is going to change over time and at various institutions. So I just wanted to reemphasize the principles here are really moving from the coverall, from the yellow gown, is the protection of that head and neck, and one can do that in a number of different ways, whichever way your institution chooses. The training and having somebody help you with the doffing and observe the doffing, having a doffing coach, I think is going to be really important.
And Hillary, if I can add one other piece to that, just to give people some reassurance, because seeing that some people you can't get the coveralls. There are other combinations of PPE that can work to give you equivalent protection. So for example, we had also used head covering, wearing a typical surgical bouffant cap on the head. And there are some visors that are available that actually have a bib that sort of hangs down. And the combination of the bouffant and the bib on top with the visor, we tested that with Glow Germ, and that plus a long surgical gown actually worked quite well. And we had no contamination with Glow Germ during that testing. So I don't want people to feel like, if you're not getting coveralls that, that you're at risk. There are other combinations that can work quite well. The second thing I do want to emphasize with the coveralls, just be careful because a lot of people get confused between Tyvek suits that you use, for example, for chemical situation, CBRN, where you do decontamination, all of that, versus these coveralls. And I usually distinguish between them because those Tyvek suits, A, are even harder to get, and B, they're tend to be a lot sort of heavier and a lot hotter. And you don't need that. We're not talking about chemical warfare protection. What you want here is something that's going to be, impervious to fluids in general, and is going to be also balance that with breathability while you're in these. So don't feel like you have to get the chemical Tyvek suits for this if that's unnecessary.
Great point, Randy. And again, going to those principles here of the neck protection and not being so specific about what exactly is needed. As long as one sticks to the basic principles, there's a number of different variations of PPE that can accomplish all those same things.
Randy, while you're talking a bit about this, can you comment a few things? The middle picture, the person has their shoes on. There's a lot of talk about disposable versus buying non-disposable masks or respirators, use of shoe covers versus no shoe covers. Could you just do some comments, first of all, on shoe protection, whether we should be wearing like rubber boots or something? What's the ideal? Should we have shoe covers? And the second thing about non-disposable masks.
Sure, a couple things. So with regards to the shoe covers, we found during SARS that, the basic sort of shoe covers that we typically would wear in the OR, the ones that sort of go up over the shoe, they are just as hard to put on as they are to take off. I think I've taken up my back a couple times trying to bend over and trying to get those stupid things on or off my shoes. And I think we've learned that the risk with those types of shoe covers of taking those off, typically people sort of try to get them off their feet and snap. When that happens, you're more likely to contaminate yourself. So that's an issue. So I think probably more important is having a gown that's as long as it can be to try to cover as much of your legs as possible, and probably a good idea to wear shoes that you can actually wipe down. This is probably a really bad time to be wearing canvas shoes that soak up coronavirus juice. You want to have some kind of clogs or shoes that you can actually wipe down after to help. So on the far right of the screen showing the coveralls, for example, those coveralls have booties on them, and so that will cover your shoes. So that's great, but not everybody's going to get coveralls that are going to do that. Certainly the little ones that cover your shoes I wouldn't do. Now, some people with their Ebola preparedness had bought these sort of big, almost boot covers that go up higher. That might be a little bit more reasonable if you have those, because you can sort of roll those down and get them off your feet if you're really worried about it. And certainly if you have very short gowns, that may be a reasonable thing to do. But just remember, every extra step that you're adding creates trouble. Rubber boots were part of sort of Ebola preparedness, partially because we were worried about wading in big pools of Ebola blood from these patients with, hemorrhagic fever and other things. And so rubber boots may be overkill in some ways, but if that's the only thing that you have in terms of footwear that maybe extends up a little bit higher and are easy to wipe down, then certainly that's a reasonable thing to think about to augment the gowns if you don't have the coveralls. And then the other question I think was about reusable mask respirators. Was that what you asked about as well?
Yes, could you comment on that?
Sure. I mean, well, first of all, just be aware, like there's a lot of talk right now as the N95 supply is, becoming a challenge. People are looking at different ways to potentially even reuse non-contaminated N95s. Although most people agree if you had an aerosol generating medical procedure, you should throw out the N95 afterwards. That's not one that you would want to try to reuse and recycle. But the idea that people are talking about is that if you bag these respirators for long enough, eventually the virus is going to die. And so depending, some people talk about 3 days, some people talk about 7 days, but certainly after a period of time, if you've had an N95 stored away and it wasn't really contaminated, even if there is any virus on it, it's no longer to be usable, it's no longer to be infected. So don't do that without clear guidance from your infection control people in your hospital, but that's something that people are definitely looking at. The more complicated respirators, like these P100 things that the painters use, or full frontal masks, things like that. I mean, certainly those would work, but the challenge you have there is when you've got reusable things like that, you've got to be sure that you're decontaminating well. And so I'd be very cautious about using any of those reusable respirators unless you're very well trained in that and making sure that you clean.
Can I ask a question to the panel? It's Laura here. So, I've got my face shield, and Randy, you were saying that sometimes you can get commercially available neck extensions on a face shield. How does the panel feel about us making up our own? For example, a sticky drape that's sterile and putting that at the bottom of a face shield instead. Has there been any guidance about, for lack of a better word, MacGyvering solutions to address, for example, neck and wrist deficits or shoes deficits?
I can comment on this.
Please.
So I think what we've tried to do in our simulator, where we have our people practicing donning and doffing, is emphasize that because supply is evolving, there are concepts that need to be emphasized about donning and doffing in our PPE rather than specific items and steps. And so what I mean by that is that one of the concepts we emphasize is whenever you're donning, you want to be considering doffing. So you're donning in a way to make doffing the least complicated and potential for contamination as possible. So if you are going to MacGyver something, you must make sure that it's doffable in a way that you're not going to be contaminating yourself. That would be my recommendation.
Shannon, I think that's probably the most quintessential point of this call, to be honest with you. So in the SARS experience in Toronto, 40% of healthcare workers, it was linked back to their doffing procedure. And so I think meticulous doffing is essential. We cannot diagnose ourselves for contamination. We must have a coach there. It's the number one thing in a 2019 Cochrane review of PPEs that has been shown to decrease contamination. The most bang for your buck is having a coach that watches you doff.
So I want to get back to our case. We're talking about that 49-year-old with COVID-19. So you've doffed your equipment, you've put it all on. Can we just have some comment, and maybe Randy, you could comment on negative pressure versus positive pressure, because this is coming up a bit. So if I'm going to intubate a patient, where should I do it? And what are the differences in terms of how I should approach someone in a negative pressure room versus a positive pressure room for my own personal protection?
Sure. So I mean, the personal protective equipment, basically, regardless of where you're doing this, if you're doing the high risk aerosol generating medical procedures, you want to do what we've said, which is, your N95 respirator and basically the head to toe coverage. But where you're doing it is an important question. And so in an ideal world, all of these high risk aerosol generating medical procedures would be done in a proper airborne isolation negative pressure room with the appropriate number of air exchanges and having them properly tested to make sure that the flows actually go where the air is supposed to go. The reality is that the number of patients are potentially overwhelming the number of negative pressure isolation rooms available. And so in general for hospitals, people are having to be a little bit more creative. So I think the downgrade of infection control precautions required to contact droplet for routine care of these patients will help, because that's going to free up more airborne isolation rooms for the high risk patients. In an ideal world, every ICU bed, for example, would be negative pressure, but it isn't. And so what some places are being creative about is designating one particular proper airborne isolation room as a high risk procedure room. And so if you've got like an elective intubation from somebody you brought down from the floor and you got to intubate them, you take them directly to that room, get the procedure done, and then move them out to a non-airborne isolation room for routine care. And that's probably a good strategy when you've got a limited number of true negative pressure isolation rooms available. The second thing I'd comment on in places that don't necessarily even have that, certainly a single room with a closed door, that's better than nothing. And then there was portable HEPA filters that you can put into rooms to filter the air, and that actually helps potentially as well. So what you want to do is add as many environmental controls as you can to try to clean the air and reduce the risk of spread after or during a high-risk procedure to areas outside that room. Operating rooms are a big challenge because for our patients' benefit, we've designed those generally as positive pressure environments. We're deliberately blowing the air over the patient and out the room, which is the exact opposite of what we want to do in these cases. And so people have had to be very creative about deciding where to do these procedures. So for example, some places people have been able to make adjustments to their airflow in the operating room. And in addition, adding a HEPA filter that's running by the head of the bed to try to reduce any environmental contamination during the airborne procedure. Other places are actually doing intubations, for example, in separate airborne isolation rooms, getting the airway secured. And then once the patient's intubated and on a filtered secure circuit, you've really significantly reduced any kind of risk of spread. And then you can move that patient into the operating room with your normal airflows to your procedure, but then you've got to move them back out to extubate them in a negative pressure environment. It's still an evolution, and every center is sort of struggling with this to figure out what to do based on the design of their environment that they're working in and the environmental controls that they have. So really important that you touch base with your engineers in your hospital, look at airflows and try to have a better understanding of what you can and can't do, and also making good use of these portable HEPA filters that can help reduce the risk as well. I hope that answers the question.
Yeah, no, that's great. So what you're saying is we can safely intubate people in non-negative pressure rooms. Would that be fair to say?
Well, so the situations where you may have to intubate in non-negative pressure rooms, one would be, an unanticipated crashing patient with a protected code blue or intubation on a ward that's not negative pressure. And so you're going to do the best you can with the environmental controls you have, which means going to be closing the door and using, your enhanced PPE. So that's one situation where you really don't have a choice. We should really try to prevent that by doing more controlled intubations rather than having crash intubations. But, it is going to happen. But I think you have to work with what you've got. And so whatever environmental controls you can have, always do the best you can. But, if you don't have a negative pressure room available, then at the very least, make it a single room with the door closed and everybody wearing the enhanced PPE. And if you can make adjustments to airflow, you do it. We, for example, converted all of our critical care units in my hospital. It's not technically negative pressure, but we could change the airflow to negative flow. So we at least know that all the air is flowing into the ICU and not out of the ICU, which means that we'll at least be confident that we're not going to be spreading anything inadvertently outside of the critical care unit in case we have to do a procedure inside a single room that isn't an airborne isolation room.
Okay, great, thanks. Shannon, do you want to comment if you're working in Vancouver and you've got a COVID positive patient? How long would you leave your PPE equipment on if you're in the OR and you're doing the intubation? And how long would you leave it on if you're doing an extubation?
Yeah, so there's, this is a complicated topic, and I think there's two scenarios that actually come up with your question. So the first is in the OR, as you mentioned, and so there have been protocols published in the CJA that outline that the PPE should be used for the duration of the procedure. Airborne precautions should be used for the duration of the procedure. So that's pretty clear. I think what's less clear and what our site has encountered difficulty defining is, say you're in the ICU, either in a negative pressure room or in an isolation room without negative pressure. How long do you have to have airborne precautions on that room for the RN who needs to go in and do bedside care? And unfortunately, the literature is pretty unclear on this. And I think the reason for that is that it's based on the number of air changes per hour of your room. And so I'm in a really old hospital. Our IPAC has said that we have 6 air changes per hour. And so we've classified an hour as a reasonable time to have airborne precautions after intubation and extubation. However, the new standard is 12 air changes per hour. And so then you could get away with a lower amount of time post-intubation and extubation, that airborne precautions will be required for anyone going into the room. So we've emphasized to try and limit non-essential care of patients after intubation and extubation to avoid putting the RN or whoever is going in the room at risk of aerosols, because it is a moving target and pretty ill-defined in the literature. The other thing that I wanted to mention was Randy alluded to early airway management as a recommendation, and in his paper in the CJA, there's really good guidelines on how to manage the airway and modify your airway management in these COVID patients. Another really good resource is the Anesthesia Patient Safety Foundation has released good guidelines on this topic. And then just finally, actually I've been working with Hillary to push out a letter that's in press now that will be published in the CJA, that our team, our SIM team here, has published our protocol, so that if people want to test their own PPE, there is a simulation protocol available. People can follow me on Twitter, and I've been trying to release protocols that are multi-site collaboration here in Vancouver with Vancouver General, Fraser Health. As we release our protocols, we're trying to push them out so they're available to people.
And sorry, it's Randy, just one other thing to add. So there's this evolving algorithm that just keep an eye out on Twitter, because I'm sure it'll be circulating very shortly, that based on some work out of China and Italy, their experience about how to sort of triage and identify patients who are likely to deteriorate. One of the good pearls in this one that we're realizing is that the arterial blood gas is very important, and the PF ratio on the arterial blood gas tends to be a better predictor than just looking at the patient for predicting patients who are likely to get into trouble. So that's going to be one thing that's going to be helpful as part of these protocols. And the second is there's something called the ROX index, which basically looks at patients on high flow nasal cannula and some predictors as well to figure out who's most likely to crash within the next 24 hours. So there's going to be a lot of stuff circulating within the next 24 hours, I think, out there. And that'll help. Sorry, somebody asked what's PF ratio. So PF ratio is the PaO2 to the FiO2 ratio based on your arterial blood gas. And so a PF ratio of less than 200 is concerning for a patient who's potentially high risk when they're on supplemental oxygen. So that's something to look at. But people are still tweaking these protocols, but I think they're going to be out there as guidance within the next 24, 48 hours. So just keep your eyes open for that on Twitter. I'm sure that's where you'll see it first.
Okay, great. Just before we keep going here, I just want to remind people there is a ability to ask myself questions. If you want to fire in questions, please feel free to do so, and we'll endeavor to get as many as we can answered. Hopefully there'll be themes. I just want to keep going on this theme of the intubated patient and maybe the transition. So maybe Laura, you want to comment? Let's say we decide not to extubate our patient, but we're just going to take them to the ICU, to the negative pressure room. Is that okay? Can we transport people who are intubated with COVID-19 down the hallways? And do you have any tips or techniques about transferring the patient to, are we going to Laerdal bag mask or portable ventilator? What precautions are we going to take when we go over there? And then I will get Randy to comment on what precautions we should take with the intubated patient that we're maybe being consulted on to take them back to the OR. So Laura, do you want to start us out?
Sure. Daniel, it's an excellent question. The first question of that being, should we intubate everybody in a negative pressure room, and what's the balance between needing to come up 3 floors to the operating room, for example, and then transfer them back, or should we just do it in a high turnover air positive pressure room in the OR? And I think that's very hospital specific, but things to look at. The transfer of the patient from the OR or emerge to an ICU, first of all, once they're intubated, they do not need a negative pressure room. They're intubated. And so the transfer itself is a high-risk procedure. It actually warrants a lot of people in PPE and a lot of resources in order to transfer that patient safely. We're going to have a number of recommendations in the Canadian Airway Guidelines, but I think one of the more important things is to emphasize the need for a clamp. So there should be an endotracheal tube in, followed by a HEPA or HEM filter, a HEM filter, and then ideally a waveform capnographer, followed by a means of positive pressure ventilation, be that a bag or attached vent, and then an oxygen source. And that will all come clear later on this week when we publish. And it's also available in the Australian guidelines online at present. One of the most important things that we need to think of for our own safety is what happens if the endotracheal tube becomes disconnected from the filter, or what happens when the filter clogs, or if the filter clogs. And once it gets a lot of moisture in it, it can clog. So I think it behooves us to have a clamp on every bedside of these patients when they're being transferred in the hospital. To clamp that endotracheal tube to replace the filter if it becomes clogged, or to reattach it. So just like we do in wired jaw patients, where we always have a wire at the bedside, we should always have a clamp for these patients. It should not be serrated. It can damage the endotracheal tube. So plastic clamps, those blue ones that are often used in ICU, are very good, or some sort of atraumatic steel clamp. But I think that's a major basic safety issue. And I think every hospital needs to make up their own protocols with these in mind, and to balance transfer in the hospital with negative versus positive pressure, high turnover room.
And it's Randy, just to add a couple of tips that have been evolving that have been, I think, very helpful. Taping the connections to try to reduce the risk of disconnect during transport is incredibly important. One of the tips is when you tape the connections, leave a little gap in your taping. So if you tape it sort of longitudinally rather than sort of around, leave little gaps so you can make sure you can actually see that the connection is still intact. Because what people have been saying is sometimes if they tape it circumferentially so you can't see the connection, it comes apart if you didn't do a tight enough taping job, but you just can't see that because you can't see through the tape. So that's one strategy. The second thing, what I think even the most useful suggestion that I've seen, and this is from Orange Transport Medicine, our air ambulance program in Ontario, they're actually taping the connection between the endotracheal tube and the filter, but they're actually not taping the connection between the filter and your ventilation source. So the idea being that if there's some kind of tug on that whole circuit, if it comes apart between the filter and the vent, it's not a big deal because your filter is still there. But if it comes apart, if you lose the connection between the endotracheal tube and the filter, then you've got a direct open connection between the patient and the environment around. So that was actually kind of a brilliant suggestion from them, which I think kind of makes sense. Like if you got to let the disconnect happen with the path of least resistance, let it happen at the point where the disconnect is going to be safe, as opposed to a disconnect that's going to be dangerous. So anyways, think about doing that. It was a brilliant idea from the folks from Orange and something that we should definitely share.
Okay, thank you. I'm going to, there seems to be a theme in some of these questions, and I'll open it up to the panel, but maybe Shannon, you could start. So one of the themes is if you have a COVID-19 positive patient who's coughing, from that video, it seems that they're producing aerosol, that it's spraying all over. So what's the difference between aerosol generating and someone who's actively coughing with COVID-19? Can you just address that for everybody?
Absolutely. So again, unfortunately, there's not a lot of literature or evidence to support this. And I know there's been some press that talked about the potential of COVID being airborne, but unfortunately they were misinterpreting information that when aerosol generating medical procedures are done on these patients, then COVID can become airborne. And so those are incorrect statements at this time with the knowledge that we have. So at this time, with the knowledge that we have, coughing patients are releasing droplets, and those droplets are becoming contact on those patients. So a coughing COVID patient should have droplet and contact precautions. when you're performing an aerosol generating medical procedure, you are creating aerosols, which Dr. Duggan mentioned are less than 5 micrometers, and those become airborne and stay in the air. And so for those aerosol generating medical procedures, you would need airborne precautions. For the high risk aerosol generating medical procedure of intubation, we are recommending enhanced airborne precautions with some type of neck protection.
Okay. And can you address another common theme right now is use of N95 for all intubations. A lot of people are saying, well, we're deciding to use N95s if we're intubating anybody in the OR now because of the high spread of COVID in the community and asymptomatic patients. Shannon, do you want to comment on it? And then maybe Randy, do you want to comment on that also? It could be the potential for intubating in the ICU as well. Should we be all wearing N95s even if it's not for COVID-19? Or is there a patient you wouldn't wear N95 if they were coming into your ICU or your OR?
So I think that's a complicated question because this is a dynamic situation. So what it brings up is community transmission. So different provinces have different methods of communicating the risk of community transmission. In our province, we're advised on a daily basis if there's low, moderate, or high risk of community transmission. Currently, we're at moderate risk, but what that has to take into account is how much testing is being done. And so once we know that it's present in the community, we also know that there's asymptomatic spread of infection. And so it's true that when you're intubating somebody who is asymptomatic, you're not guaranteed that they are not a COVID carrier. The problem with our testing is that when patients are asymptomatic, the sensitivity of the test is very low. So in an asymptomatic test, or in an asymptomatic patient, a negative test does not guarantee that that patient does not have COVID. However, the problem that we're currently facing is a limited resource of N95 masks. And so I'm heartened by the fact that our manufacturing industry has turned to producing this amount of PPE, because I think in an ideal world, we would all be wearing N95 masks for these procedures. However, at this time in our community, at our site, the risk of community transmission is moderate, and thus for these asymptomatic patients, we are currently donning droplet and contact precautions as per there's a SHEA society recommendation that this actually should be the standard of care for any patient being intubated even pre-COVID. So we are double gloving with nitriles, putting a mask and a surgical visor and a reusable gown on for unsuspected COVID patients.
Dan, it's Hillary here. Let me chime in just for a moment because I just want to reemphasize a really important point, Shannon, that you just mentioned, and that is, once this pandemic passes, I think this is a really sort of pivot point for us in the management of regular patients and how we intubate these patients. I think for a long time we haven't used proper droplet precautions in intubating patients. I mean, if you look at yourself and your colleagues across the country and ask who is wearing a face shield or double gloving for routine intubations, we're not doing that. But this is actually a lesson that we can learn from this, that we can then essentially make the new normal in managing patients who are not at risk for COVID, because eventually this is going to pass and we can take some of these lessons here and enhance our practices and our safety moving forward.
And Hillary, it's Randy. Just to comment on this, I'm a big Yogi Berra fan, and this is all deja vu all over again. So what's very interesting is during SARS, we instituted at that time all aerosol generating medical procedures required N95 mask with the precautions. And that actually was on the books for a number of years, even after SARS passed, taking all this into account. And what was interesting is a few years later, those recommendations sort of magically disappeared, and we kind of went back to the baseline. And so this is a lesson that was learned and then forgotten. And I think part of our challenge is that there's kind of a generation of healthcare providers that lived through SARS and remember some of those lessons, and we have a new generation of healthcare providers that maybe didn't live through that. And so we're fortunate we've still got enough people around who sort of remember those things. And it's unfortunate that some of that was lost over time. I think we maybe got a bit complacent. And so it'll be really important to have the conversations after all this is done to rethink so many things about what we do. Obviously things like logistics and bed capacity planning and negative pressure rooms and all of those things need to be thought all over again about, being ready for the next one. But this is actually a really important concept. And it is kind of funny because the number of times I've seen people, over the years intubating with no PPE on whatsoever always scared me because I have memories of all of this back in SARS. And hopefully people will learn the lesson again and will think about appropriate precautions for all patients going forward.
Great. I'm still going through your questions, and there are a lot of questions, so please bear with me. I just do want to move on in the interest of time because I think CPR is one of those areas that people are interested and concerned about having to attend someone who's had a cardiac arrest. So, Randy, do you want to just talk us through if someone arrests in your ICU right now and they're extubated at the time of the arrest? What sort of protocol would you have in place? And do you make any distinction between COVID low versus COVID high risk?
So a couple things. So, I think anybody who's under COVID precautions for suspected or confirmed COVID, you treat all those patients the same. So presumably anybody who's not under COVID precautions, they would be different. But anybody under COVID precautions, so we've looked at the literature about the risk of different interventions during resuscitation. So certain things we think can be done with basic droplet contact precautions. So that includes, so for a patient who is full cardiac arrest, putting on a non-rebreather mask with a filter. So that's like a Tavish mask or a Hyox mask with a filter to allow passive oxygenation during CPR seems reasonable. But we looked at the risk of doing chest compressions with only droplet contact. And because there was some data, it's a little bit controversial, some data about the potential risk of transmission during chest compressions independently. Our organization, for example, has decided there's no chest compressions unless everybody in the room is wearing an N95. It doesn't necessarily mean you need the whole, high-risk aerosol-generating medical procedure outfit, but at the very least, we want people in an N95 before we'd start compressions. Now, defibrillation, again, that's something that we think would be low risk and could be done for people wearing just contact droplet PPE. And this has actually become much more relevant, particularly with COVID, even compared with SARS, because we are hearing lots of case reports of patients developing a very rapid fulminant cardiomyopathy and actually having sudden onset ventricular arrhythmias, even in patients that actually look like they were getting a bit better from a respiratory perspective, and then end up having a sudden cardiac arrest with a ventricular arrhythmia. So the ability to get first responders into the room with an AED or a defibrillator and being able to give a shock for a shockable rhythm, even though they're wearing contact droplet precautions, I think that's really important. And then we developed protected code blue teams. So in order to do things like intubation or chest compressions, ideally you've got a team that's going to be able to respond and in our high risk PPE like we would for any intubation, but just recognizing that may introduce some kind of delay between the first responders doing things but not starting compressions, that they don't have droplet mask or they don't have an N95 mask on, and the starting of chest compressions. It really runs counter to our instincts for what we would normally do for a cardiac arrest. But in this case, I think you always have to put the staff safety first and make sure they've got the appropriate precautions before they can go ahead and deliver those interventions. Final comment is just, I think we have to be very clear on advanced directives. And so certainly people who are in multi-organ failure, refractory respiratory failure, these are people we should not be performing CPR on. And so I think every province is a bit different in terms of their rules and regulations for how to handle that. But I think just in general, somebody who's in multi-organ failure who we normally shouldn't be doing CPR on even pre-COVID, we definitely shouldn't be doing that in a post-COVID world. And the second thing is on the wards, if you have a patient in unwitnessed asystolic arrest, so you come and you find this patient basically vital signs absent and you put the monitor on and they're asystole, I would at that point stop the resuscitation there, and I don't even think I would intubate them. I think I would just stop, just knowing that the outcomes of unwitnessed in-hospital asystolic arrest are horribly dismal. And then you add the risk to providers in this case. I think I would just stop the resuscitation if an unwitnessed asystolic arrest is confirmed, and I would not manipulate the airway, which would create unnecessary risk to providers. That last point may be a little bit controversial, although I have to say, you know, if I speak to 100 people, about 100 people agree that that sounds pretty reasonable, but some people may or may not agree with that.
Okay, great. Does any of the panelists want to comment on CPR in the extubated patient? Okay. I'm cognizant of the time, and we've got about 15 more minutes. Just for people, I've got a lot of questions about people who couldn't tune in, or you've missed one section, or would like a list. We're going to make the slides and the recording of this presentation available at the CAS website, hopefully by tomorrow, but if not by Tuesday for sure. So if you've missed parts of this, or you want your colleagues to be able to listen to it, it will be online shortly and available for download for anybody who needs it. Okay. And again, just cognizant of the time, I'm still getting a lot of questions about aerosol generation, coughing and sneezing, airborne precautions, and all of this. So Laura, do you just want to go through this one more time? Because I think we have to make a real clear distinction here between coughing, sneezing in the COVID-19 patient who's versus airway manipulation. Could you just address that for us again?
Yeah, so an excellent question. Can we go back to the PPE slide?
Yeah.
So I think, you know, for the sake of keeping it very, very simple, the central figure is kind of equivalent to the figure on the right. And both of these should be considered for highly invasive situations, such as the need for positive pressure mask ventilation, intubation, and tracheostomy or cricothyrotomy. And so that's aerosolized particles happening, versus the one on the left is excellent for droplet and for contact precautions. So unless you are and I am really looking forward to seeing what the other panelists say about this, but my mental model is that unless you're doing a highly invasive procedure, that the PPE on the left is adequate for droplet precautions and for contact precautions, and a patient that is spontaneously ventilating but producing these should be wearing a mask, and you should be wearing a mask at all. I would like to know what the panelists think about an N95 mask for both the patient and the provider when it's droplet and contact precautions only versus a plain surgical mask.
Randy, do you want to address that? Start with that, and then we'll go to Shannon.
Yeah, sorry, can you clarify that question again? So you're wondering
if you're just doing droplet and contact, should you have an N95 mask? If the patient is in your ICU and they're coughing and sneezing, should you have an N95 mask on?
Yeah, so in general, as long as you're not performing a high risk aerosol generating medical procedure, if you're wearing a droplet mask for the staff, and if the patient is wearing either a droplet mask with the nasal prongs underneath, or if they're using one of the non-rebreather masks with a filter, if they're coughing and sneezing, you're creating a physical barrier and trapping most of that to reduce the environmental contamination. And I think the social distancing as well, keeping that distance between you and the patient, even though everybody's wearing a mask. So you put all those things in combination, and I think it would be okay. That's certainly the recommendation at this point. The other piece of that would be reducing the potential need to go in and out of the room. if you can. By that, like, people are looking at opportunities for things like IV tubing under the door with the pumps outside, so you can reduce the need to go in and out. So I think the whole concept of social distancing with all of this, even despite droplet contact precautions, is, I think, a useful way to reduce that. But just in general, though, it just for routine patient care with coughing, et cetera, it's not recommended that people have to wear a 95 mask for that.
Yeah, I would agree. And I would just want to clarify that in no case should the patient wear an N95 mask. The patient should wear a surgical mask, and the N95s are for the healthcare practitioners. And I would echo what Randy said in that unless you're doing an aerosol generating medical procedure, droplet and contact. Once you're doing an aerosol generating medical procedure, N95.
So this is important because we don't want to be wasting N95s in unnecessary situations, potentially putting people in at risk. So what I'm hearing is, because if they have a mask on and we can be more than 6 feet away and we don't have our face close to their mouth, we should be protected so long as we have a droplet contact PPE on. Would that be a good summary?
Dan, it's Hillary. Let me just chime in here for a second. I think that's a good summary. I think the other important point is that we have to be good messengers for the people around us. And if we as anesthesiologists are seen, inappropriately wearing an N95 mask, that's a message to the other healthcare providers around us. We need to be leaders on this. And I think what we've done here is really nicely prescribe where they should be used appropriately. And I think we need to continue to lead in this respect.
Yes. So, sorry, I agree with you 100%, Hillary. I think that's very true. I'm just going to raise, and this is another sort of theme too, and maybe Shannon, you could address this, anti-rooms in terms of areas to don and doff. And again, can you just say, if you're in the OR, you've just intubated a patient, the surgeon's about to come in, the nurses are about to come in, do they need to wear the full AGMP for the PPE for AGMP in the OR if you've intubated them there? Should they wait and come in after it's cleared, say an hour or 2 hours? How long should they wait? What are your comments on that?
Yeah, so to address your first question about the anti-rooms, so in our site in the Emerge, we have 1 negative pressure room with an anti-room. We have 3 isolation rooms with negative pressure without anti-rooms. And so the general theme is that if you have an anti-room, everything comes off in the anti-room. If you do not have an anti-room, your external your external contact layer comes off in the room. You wash your hands in the room, and then you leave the room and you take off everything else. So that's the theme. So that would be your gown and your gloves or your contact layer. That would come off in the room, go in the garbage. You wash your hands, and then you leave the room, and outside you meticulously take off the rest of your protection. And then to address your second question in the OR, so I think, again, the concept that can help guide your decision-making is that for an hour in our hospital, depending on your air exchange frequency, there are aerosols. So if anyone comes into the room for an hour after intubation, they need airborne precautions. And I'm not saying they need intubating precautions. I'm saying they need routine airborne precautions because it's the intubation itself. So the person in the face of the COVID infected patient that needs the enhanced airborne precautions that I'm talking about for intubating. So anyone who comes in the room for an hour at our site afterwards is required to have routine airborne precautions. So if you're going to delay, if you're going to induce your patient, intubate them, and delay for an hour, then your team may not need aerosol generating or protection for aerosol generating medical procedures. However, the article that came out from Singapore is recommending that for the duration of the case, the team wears airborne precautions. So again, it's dynamic, and it's decisions that need to be made with an understanding of why they're being made. And so I think it's safe to say that in the OR, the team, if you're not going to delay, the team should all be in airborne precautions.
Great. So we're sort of running at the end of time. We can go on for a few more minutes with questions. I just want to go through the end of the slide sets. I just put this out there. We did send off a letter to the Minister of Health. We actually sent one to the Prime Minister as well, requesting PPE equipment. What we will plan to do moving after this meeting is, again, send out another letter, again, requesting the PPE equipment that we need, which we've discussed today for AGMP procedures, is made available across Canada. And we'll do our best to continue to lobby federally and provincially for the right equipment to keep everybody safe. Just that our numbers continue to climb, and hopefully, I think for all of us, we hope this distancing plan will work, but we are seeing continued increases in the numbers. We're number 17 in the world right now for total number of cases, about the same level of Australia. So unfortunately, we're still seeing increases in cases and increases in deaths. Is there any comments any of the panelists want to clarify? Anything that I've missed?
Yeah, and it's Hillary here. I just wanted to sort of make my own sort of summary statements here, because I think we've had a really progressive discussion here, and a couple of the takeaways that I've learned from this today is this concept of enhanced PPE, the neck protection, and all of the things that we need to do to protect ourselves. I think the need for a doffing coat, very, very important. The need for protecting yourself afterwards and showering afterwards to get rid of that sort of residual COVID that might be on your body, incredibly important. The other thing that I've learned here is that we are moving into a period of the new normal, and we are going to have lessons that we're going to move forward from this. And lastly, there is an absolute massive information that's accumulating both online, in publication, and I think people need to look to credible sources. I think a webinar such as this, and I really thank the CAS for putting this together, I think this is a real help. Look to the peer-reviewed literature as it comes out. Yes, there's some really important information on Twitter as well, but it's just going to be take a long time to sort of sort through this massive information there. But this has been very helpful for me. And lastly, I would say that we need to protect ourselves here, because if we can't protect ourselves, we're not going to be able to protect others. And we've seen from other jurisdictions that the number of healthcare infections continues to be a problem. We need to sort of shift this paradigm and, yes, put patients, at the center of this, but we have to first protect ourselves. Otherwise, we're not going to be there for them at the end.
Yeah, thanks, Hillary. That's great. I think we should really recognize the stress. I think this is putting everybody under. This is very stressful. We're concerned about our families at home. We're concerned about ourselves. We're concerned about our patients. And I think I just want to acknowledge the fact that we're all feeling very stressed. This is a big change in our lives. And I think a lot of us are struggling with it. And I would just encourage everybody to keep an eye on your colleagues, and if they need support, offer support. And if you're one of those people who is really in need of support, that you go looking for it. There's a lot of resources out there for mental health and just stress relief issues. It's a huge issue. And I think we have to be very cognizant of that. We are going to try and hold another webinar next weekend looking at specifically airway management, but we will also have PPE if there's any further questions available. As I said before, we will post this webinar online, and I would encourage you all. The CAS has done a really great job of putting a web page together, cas.ca. The COVID-19, this is where this webinar will be posted, but we have a whole range of other resources, a lot of them that were mentioned today. So if you're looking for the resources that are on the slides will be there also. If you're looking for a repeat of the webinar or to share it with colleagues, it will be there too. And there's a whole host of other recommendations and other sites that you can connect onto. Lastly, again, I'd like to thank the CAS for getting this going, and the office staff in particular. They worked really hard. And I'd actually like to really thank the speakers. We've spent about 3 hours before this webinar back and